illness or disease. So there's also been recommendations from the National Academy of Medicine that have recommended that we begin to develop and deploy appropriate training and education programs to ensure that clinicians are prepared for this disruptive technology. And then we can see here on the right, there's a paper published by colleagues of mine who I recently had a wonderful opportunity to partner with them. I recently had an opportunity to partner with them for a workshop related to this topic. But this is a paper that's been pretty important and that we've kind of used to some extent as a foundation for many of the conversations that we've had related to this topic. And then when you look at a poll that was sent to educators, what they noted was, or what the educators noted was that, the second most important topic that medical schools should focus on is to prepare students to succeed in clinical practice by using data science, which includes artificial intelligence and machine learning. So second highest was rated by clinicians back in 2020, or by educators back in 2020. So currently, AI has a minimal presence in medical education curricula. It's mostly in the form of non-mandatory offerings like electives, online courses, workshops, certificate programs, and interest groups. And I know that you had some students here. I know Katie, who's been working on a curriculum along with Jen. They've been working on a curriculum for medical students. And I certainly applaud that for that effort, but I'm sure that they would agree that there's going to have to be a bit more given the disruption or the impact that this technology is going to have on healthcare. So, I would say generally, when it comes to these offerings, it's not going to be sufficient. We're going to need to do a bit more as we move toward that biotechnomedical model. So there's some barriers potentially to implementing this content into curricula. So, and these barriers could potentially differ depending upon the organization, the school department. They'll certainly be unique barriers, but I think there are some that are a bit more generalizable. So understandably, and perhaps appropriately, there's some skepticism related to AI and ML in healthcare. And I welcome skepticism as a EBM teacher and practicer, as I'm sure many of you are. I often teach my students that skepticism is great. It's good. Ask questions. But cynicism is what we have to try to avoid, right? Cynicism is definitely what we have to try to avoid, keeping an open mind. And then there's the issue when it comes to lack of buy-in from relevant stakeholders. This may also be a significant barrier. I'm excited. Again, when that workshop that I told you about, it was hosted by the National Academy of Sciences, and I was fortunate enough to be a part of that planning committee. And it was cool to see the AMA and the AAMC and multiple leaders in health professions, not just medicine, coming together to figure out how to begin to implement or have this content included into our curricula. And then a lot has been written about going from development to deployment of models in clinical practice. And the issue with that is that, yeah, we're not seeing a lot of models that are currently actively present in clinical practice, which means that clinicians are not engaging with the models as much. So they're therefore potentially not appreciating the benefits of their use in clinical practice. So therefore, when our learners come from the classrooms, or they're hearing talks like this, going out into clinical practice, you have that hidden curriculum where it could potentially not appear to be as important as it was described in the classroom. And then there's also the concern about fitting new content into already overcrowded curricula. And I'll talk a little bit about that and some writing that we've done related to that. And then the other question is, who teaches this challenging or seemingly challenging content, right? So the question becomes, again, what do we do to address these barriers? So one of the things that we've written about is integration. It can be overwhelming to think about creating a new course or instruction in AI or ML and then fitting this into a curriculum. It could be much easier. It may be a bit more comfortable to think about integrating this content into existing curricula, like evidence-based medicine or health system science or clinical reasoning courses or doctoring courses. This is something that at the University of Michigan, with me having control over, so to speak, or oversight of the evidence-based medicine curriculum, I am able to introduce this content into that curricula. Similarly, with having a role within our residency program, the same is, I'm able to do the same thing there. And I'll talk a little bit more about that, but it's still not going to be enough. I anticipate that this integration is going to be what we see happening over the next 1 to 2 years as we're kind of gearing up for more aggressive incorporation of this content into curricula or into the broader curricula. An interprofessional, interdisciplinary effort is going to be necessary for this. Absolutely essential. So we have to begin to consider whether or not engineers, computer scientists, those developing AI ML models for use in healthcare will become as integral as the biochemist, the geneticist, the immunologist, the pharmacologist, the physician, and others with firmly established roles in medical education. Will they be considered, will those computer scientists, engineers, even lawyers, will they be considered medical educators? Additionally, this space should allow multiple disciplines to come together to solve problems and benefit from one another's expertise. So while integrating AI and ML content into currently existing curricula may help with the overcrowded curricula, it's going to also be important for leaders in medical education to have some challenging, difficult conversations. And I'm talking about what needs to truly be in the curriculum. What type of de-skilling are we going to do? De-skilling meaning determining what skills are absolutely necessary for a clinician to function effectively in healthcare. I do not have the answer to those questions clearly or obviously, but when I sit down and speak to my mentor, who's now retired, or one of my mentors, it's interesting to listen to some of the things that he told me he was previously doing that we're just no longer doing. And I can even think in my, short 7 to 8 years of practice, things that I was previously doing that I don't currently do, that I probably should have stopped doing a while ago. Again, as evidence becomes allows us to see better ways to do things. And so we have to think about, how and what responsibilities are we going to delegate to computers? What important skills can we focus more attention on? Will there be less of an emphasis placed on physicians' recall and more attention? And I'm going to really briefly and quickly just mention, a lot of people are getting concerned about ChatGPT, but this point that I'm about to make is kind of related to this, in that, do we become a bit less concerned about things like recall? And do we focus more attention on information management or teaching compassion and empathy, professionalism, communication skills? These are skills, in my opinion, along with being able to effectively engage with artificial intelligence and machine learning. These are skills that are going to set apart the good physician from the great physician. It's going to also be important for licensing and board certifying organizations to begin to emphasize this content. I have a feeling that once we see it included on these exams or on their exams, that learners, educators, and clinicians will certainly pay greater attention to this content. And I will also mention that when you look at the NBME Health System Science exam, that subject exam, it already has content related to AI and ML on it. So again, I think that content is certainly coming in the future. So clinical science, these are the pillars of medical education. So it's historically, it's been considered clinical science, basic science, health system science. And I know that there's a lot of integration of these three, but historically, I would say that these have been considered the pillars of medical education. My prediction is that in the next 5 to 10 years, AI will serve as a foundation, one of the foundational elements of these pillars, in that it will be interweaved throughout every single step or every part or portion of medical education. This is the University of Michigan Medical School 4-year curriculum. This is like our curriculum. We have it divided between the scientific trunk, the clinical trunk, and the branches. So, and I've shown this slide to to individual at the University of Michigan. And what I explained was that I think even before our students or our learners start medical school, they're going to have some familiarity with artificial intelligence and machine learning. And then it won't just stop there, but again, in the next 5 to 10 years, I see this continuing throughout throughout medical school and further on into residency, meaning that that engagement with artificial intelligence and machine learning. These are the first two blocks of the scientific trunk, or of the first year of medical school at the University of Michigan. And these blocks include those foundational core concepts, the basic science that's necessary for learning more advanced concepts in clinical practice. In the future, I suspect that it's going to look like this, that we will now consider how data science and AI and ML are included in these foundational blocks. I'm going to show you a paper that we wrote later where we are considering AI and ML as a fundamental foundational tool in clinical practice. So when it comes to goals, I am not saying that everyone has to program or develop AI models. I'm not saying that everyone has to be familiar with Python and R and all of these various techniques. I'm not saying that, but I do believe that it's important that everyone has the ability to be a vocal stakeholder for and patient advocate when it comes to this rapidly moving technology or rapidly moving field. Just as we don't expect that everyone's going to conduct a randomized control trial, we can't expect that everyone's going to develop AI and ML models. But it is going to be important that our learners can do these fundamental things here. There have been some that have began to think about learning objectives and competencies. Bonnie Miller spoke at that National Academy of Sciences workshop, and we had great conversation around these competencies. And I think it's a great start, right? I think it's a great start to kind of get the conversation started. You can kind of think about AI competencies versus, do we have extensions of current core competencies and embed AI and ML into those? There was lots of great conversation related to that. But I do believe that what the individuals at Vanderbilt did, it's great to get the conversation started. And there are also someone that I know out at the University of Houston that's developed primary care specific AI specific competencies. And that's something, again, I think Bonnie Miller's group, this is great. It's a great start, but I do believe that this content is going to have to be specific to the various specialties out there. So this is the paper that I mentioned earlier, where we described AI as a fundamental tool set of medicine. So it's important, though, to note the difference between viewing AI as simply a tool versus having the ability to interact with, engage with, and team with AI. And this is a use of this tool set that we're referring to. It's illustrated in this figure, which is showing the future state of the clinical encounter specifically related to diagnosis. This is a figure that we use in a soon to be published AHRQ brief that's kind of showing the clinician is going to have these skills and interactions with AI and the clinician, and kind of serve as a moderator and or a liaison between those two to some extent. And that's not to ignore the fact that the patient is going to bring AI and or their experiences with AI into the relationship as well. So interpretation, application of outputs, and communication with AI is going to be as fundamental as anatomy, physiology, history and physical exam taking, ordering and interpreting tests. It'll be as fundamental as those things are to clinical care and medical education. Clinicians will also have to adjust to the increasing level of automation of tasks. It can be very difficult or challenging to kind of delegate and or give responsibility over to other people, let alone over to artificial intelligence, especially when we have concerns about potential efficacy and safety. But we are assuming here that these algorithms have been proven efficacious and safe. So to this end, the data augmented technology assisted technology assisted medical decision making, or data MD team, is working on curricula that are intended to design intended to teach learners across the medical education continuum about artificial intelligence. And our mission is to develop, implement, and disseminate innovative healthcare AI and ML curricula that serve as a foundation for medical educators to develop curricula specific to their own institutions and/or their specialties. And to accomplish this mission, I mentioned that the need for that interdisciplinary, interprofessional team. This is I can't say enough about how amazing this team of individuals have been. You know, I was doing interviews for the AMA curriculum yesterday with Maggie McCarr, who's a computer scientist and an engineer, and the learning from one another that we were doing and doing those interviews, it was just mind blowing. It was amazing. And I bring that up because I find that I'm having interactions with Nicholson, who's a lawyer at the University of Michigan, who's written extensively about this. Karen Deep Singh. I think this team or teams like this will be especially important to effectively implementing these curricula, not only at our local institutions, but across the country. So in 2015, the National Academy of Medicine published a document that outlined steps to decrease diagnostic error in healthcare. And they also acknowledged the importance of education and how that is going to be necessary. It's going to be necessary for us to educate our learners about methods to decrease diagnostic error. So our team, as Rena mentioned earlier, that I was a National Academy of Medicine diagnostic scholar. So my focus during that scholars program kind of focused on using technology to decrease diagnostic error, and specifically teaching learners to use technology to decrease diagnostic error. And this led to us kind of considering the National Academy of Medicine diagnostic process. And we focused mostly on this information integration and interpretation and information gathering, working diagnosis piece. And we used the evidence-based medicine framework as we developed our curriculum. And we are working with the Center for Academic Innovation at the University of Michigan, and we are planning to launch our curriculum in this year. And what we'll have are 4 widely available free online modules that'll be available on the Coursera platform. And I'm really excited because even prior to launching the online modules, one of our rising chief residents, Andrew Wong, will be incorporating this content into our internal medicine residency curriculum with formal sessions starting in May. So we'll have sessions in May and June, and we'll be kind of getting some data to determine how that's going. I also, I mentioned that curriculum that we are developing with the AMA and being in that room with Maggie McCarr. This is what I was referring to here. We're going to have 7 web-based modules that'll also be launched in 2023, but this is going to be later in 2023. I'm thinking more along the lines of the end of 2023 here. But again, it's going to provide that foundation for institutions, programs, et cetera, across the continuum of medical education to learn about these concepts and begin to develop curricula that are specific to their specialty and/or their institution. So this is my final slide, and I'm going to just say that AI and ML, as you can probably guess, or as you can appreciate from the things that I've stated thus far, moving at a rapid pace, and it's going to continue to do so with or without the input of physicians and other healthcare providers. It's going to. There are a number of stakeholders involved in AI or healthcare AI and ML. Startups are developing models and promising that their models are going to improve the health of patients. But the question is, should we rely on the word of developers as these models are deployed? As we know, the agendas of physicians and other stakeholders are not always well aligned.
Never.
All right. So given physicians' position within the healthcare system, they must become not only vocal stakeholders, but leaders in this space, in the development, the deployment, and the monitoring of these models. And this only occurs if we begin to take the steps that are necessary to train and educate patient-centered, data-driven, evidence-based healthcare providers. And if we don't take these steps, then it will almost certainly be a detriment to the patients that we care for. And I'm gonna stop there and